we are looking at very, very serious issues that are happening. This conversation is very, very interesting because last night when I was reading some of the literature, the figures I saw was very staggering, and I was surprised that it's happening, especially in Sub-Saharan Africa. So the question we are finding out, why is it that our mothers die when they go for deliveries, a childbirth, so much death across the world? But if you look at the figures that are coming from the Sub-Saharan Africa, it's shocking. But thank God that today in the studio I have great men and women who are joining me across the world. We're going to have a speaker from UK. We're going to have another professor from South Africa. But in the studio is our own. When I say our own, because one is a senior lecturer at the University of Ghana Medical School, and also he's a consultant in obstetricians and gynecology. So as we speak now, Dr. Tio Boafu is my guest in the studio.
Right.
Pretty soon, Dr. Chim will also be joining me from UK. And then we are also looking forward to Professor Pryor. Okay. Professor Pryor is also joining us from South Africa, and we'll be talking about it more. So just take and stay. This is a very fine opportunity to understand more when it comes to maternal mortality here in Ghana, in Pen TV studio. But let's begin. Doc, good morning.
Good morning, sir.
Good to see you once again.
Yeah,
though we are exchanging presentries,
yes.
If you listen to the subject we are discussing this morning, it's quite beyond, something to be taken light. The magnitude of challenges is very shocking. In fact, I didn't have a lot of information when I began to do, I started some information last night to pick certain indicators. And what I saw was very, very disturbing.
Yeah.
First of all, when we talk about maternal mortality, what's the picture?
Yeah.
And then for country-specific Ghana, where you are, you can tell us indications.
Yeah, as you said, the picture for maternal death is quite, not good. You know, and maternal deaths are very painful, I must say. One of the most distressing, unforgettable experiences couples go through. Because we're expecting that when you are pregnant, you should just have a joyous delivery of a baby and everybody's excited. But there are few couples that miss that joy. The mothers have died, left the babies. And the problems are huge. Motherless children, what they go through, we are not talking about that, but it's huge problems they go through. So mothers dying in labor and pregnancy is a serious issue. And the numbers are huge, as you said. Globally, the estimate is that every 2 minutes, we have one maternal death. So as we are speaking now, so within 2 minutes.
For the last 30 minutes.
30 minutes, we've had about, let's say 1 hour, we've had about 30 deaths globally. And most of these deaths are occurring in Sub-Saharan Africa and other developing parts of the world. Sub-Saharan Africa takes the charge of the more than 70% of all these deaths, some quote 70 to 90% of deaths are actually in our part of the world, Sub-Saharan Africa. So, if you put it together, the total maternal mortality ratio for the whole world, they are quoting about 530 or 540, against 100,000 live births. So when you have 100,000 women delivering, we have about 540 or 550 of them dying. That's in Sub-Saharan Africa. If you go to the Western countries, in fact, their figures are very small. Their average is about 11. There are some that they're actually in single digits. If you go to Japan, they don't even record. In 2023, 2022, they did not have even a single maternal death. Their population is huge. We're talking about over 100 million population. But all these people go to childbirth. Not even one person dies that you can say this is maternal mortality. It's happening in Japan. Their systems are so well structured there. We'll come to that. Yes.
We'll get to why the story is so
it's different. Yeah.
But let me, to wrap up on it before I jump to South Africa and speak to Prof. So now let me get to Prof. Prof, I'm sure you can hear us now. Thank you so much. So this Professor Pryor Soma Pillay is the head of Department for Obstetrics and Gynecology at the School of Medicine in Pretoria, University of Pretoria in South Africa, and also a chair to Steve Biko Academic Hospital as well. Such a great one, a woman who is also joining us. So, Prof, these are the information we are getting. My information is that you've done a lot of work on these issues when it comes to maternal mortality. But from your South African point, tell us, what is the prevailing situation at your end?
And good morning to your listeners. In South Africa, we've been auditing our maternal mortality for over 20 years. And since the early 2000s, the top 3 causes of maternal death in South Africa has remained unchanged. And our number 1 cause of maternal death is death due to HIV and AIDS and its complications. So although this has remained the number 1 cause of maternal death for over 20 years, our numbers have come down, and we've improved our treatment for women with HIV and AIDS, but it still remains our leading cause of maternal death. So the category in which this is placed is deaths due to non-pregnancy related infection, and HIV and AIDS predominate. During the COVID pandemic, deaths due to the COVID infection was also placed in this category, and that increased the number of deaths in this category. Our second and third causes of maternal death is death due to obstetric haemorrhage, and this is really bleeding after delivery, but more so after cesarean section than vaginal delivery. And in South Africa, in the public sector, women who have a cesarean section have a 3 times increased risk of dying than if they have vaginal delivery. The third cause is deaths due to hypertensive disorders. And really, the women die because of uncontrolled hypertension, very high blood pressures, and then complications associated with the hypertension, developing complications like pre-eclampsia, leading to respiratory compromise, pulmonary edema. So hypertension, obstetric hemorrhage, HIV are our leading causes. Number 4 is our medical and surgical categories, and in that category, it's mainly deaths due to cardiac conditions and complications of rheumatic heart disease, your mitral stenosis, and your valvular pathologies. And that's also rheumatic heart disease is really a disease of poverty and it's a disease of poverty that children get in their childhood years. Often it's undiagnosed, and women are diagnosed with this cardiac condition for the first time in pregnancy.
Back to you, but I think that this morning's conversation is centered on the Sub-Saharan Africa. I know from your end that yes, there are a lot of challenges, but the numbers in this Sub-Saharan African area is what is calling for further investigation and understanding. And so just hold on for me. I'll get back to you. Let me speak with Dr. Chim. If you can hear me, Doc, he is also, in fact, he is a deaconess of this church. Dr. Chim, great. Good to have you once again. Thank you. She is a deaconess of this church. So her name is Deaconess Dr. Chim Nkabula, who is also a consultant when it comes to obstetrician and gynecology as well. But he is practicing in UK, and also the president for the Christian Healthcare Professionals Network, a branch of COP's Workers Guild, which also was given birth under the Vision 2023 by the Church of Pentecost, headed by the Apostle Eric Nyamiche. So, Doc, good to have you once again. From the UK perspective, what's the data that you can share with us as far as maternal mortality is concerned?
Oh, thank you so much, JB. So today is a special day for us as well. As you know, CHPNet, this is our 3rd anniversary. And part of celebrating that 3rd anniversary, we thought it would be good to contribute to our community by educating our audiences on why mothers die in childbirth, especially in Sub-Saharan Africa. So in UK, I will mainly concentrate on a very shocking statistics which currently we are struggling with. Even though the maternal mortality rate in the UK is in two-digit figures, our rate is around about 11.7 per 100,000. So you can see the massive differences for Sub-Saharan Africa and for Western countries. But within that, statistics show that Black women are 4 times likely to die from childbirth compared to white women. So there are issues that affect us across the globe, and this is a global problem. But in terms of what are the maybe top causes of why mothers die in childbirth in the Western countries, especially in the UK, our issues are mainly in the last 3-year report that we had from 2019 to 2021. We are to do with COVID-related deaths, and seconded by cardiac diseases. And the third was the blood clots, so mothers dying from blood clots within the veins. And the other one, which is also very critical for us, is death from mental health conditions. So you can see that the pattern is completely different from Sub-Saharan Africa. But it is a huge problem among the United Kingdom population, especially among the Black women, that the disparity is still large, that 4 times more women in Black African ethnic minorities are likely to die from childbirth compared to the white. So as a small organization, CHPNet, our role is to educate our African communities, our faith communities, on how we can help to minimize this, or educate them and empower them. Thank you.
Still on you. So how is the Church of Pentecost in UK working through the CHPNet in trying to mobilize people for this education you're talking about?
So, as you know, CHPNet is a subsidiary of the Church of Pentecost, but the whole vision of CHPNet was to mobilize healthcare professions in various fields to come together, to network, to connect, to serve our communities, and also to transform lives in our communities. So part of the things that we do a lot of health education on women's health. We organize it in our local communities. We partner with other organizations. There are many organizations in the United Kingdom that work for the same common vision of improving health outcomes among ethnic minority and faith communities. So our role mainly is to educate, faith communities, ethnic minority communities, by talking to them about various medical conditions, access to healthy services, breaking the barriers so that, these women can go and access health services on time, but also tackling some of the cultural taboos that are within our ethnic minority groups, so that we can, break down the myths and tell them the facts about, healthy conditions, and also sometimes it's the fear of unknown. So if we reach out to them, this is also quite helpful.
All right. Now, Doc Boafo, so in trying to diagnose what's happening, especially the maternal mortality issues, in Ghana specifically, as part of your investigation, what did you find?
Yes.
What is the issue when it comes to Ghana?
Thank you. For Ghana, our leading maternal cause of death is still hemorrhage. That's the picture for the whole country. Because we still have a lot of people. In fact, the data we had from the Ghana Health Service for 2022 to 2023 shows that about 30% of all the deaths in Ghana are due to hemorrhage, followed with hypertensive disorders of pregnancy. So when women are pregnant, they sometimes develop high blood pressure. And things can get complicated. They can have eclampsia. That's when they are convulsing. And then before we say anything, it has led to death. So that is our second major cause of death. The third major cause of death in Ghana is the pregnancy-related infections. People have delivered and they develop what we call sepsis. There's infection. So these are the 3 major causes of death we have in the country. There are others, like death from certain pre-existing diseases that are already there, that just got aggravated by the pregnancy. like you have sickle cell disease, HIV, you have cardiac diseases, you have anemia already. These are also coming on board, but I would say they are not so many. The big guns is the hypertensive disorders of pregnancy and the hemorrhage. Now, in our teaching hospitals, I mean, it is the top is the hypertensive disorders of pregnancy. In fact, all the big hospitals in Ghana, we have shown that the lead is hypertensive disorders of pregnancy, followed by hemorrhage. But the whole country, when you put it together, is hemorrhage, followed by hypertensive disorders of pregnancy.
Okay. Let me get to Prof. So, Prof, Professor Pryor, I'm sure you are still on the line.
I am, thanks.
Great. So, I mean, we understand that you did a lot of study from this Sub-Saharan angle. What did you find during your investigation, and how do we improve the situation?
So we've looked at our avoidable factors, and in about 50 to 60% of cases, when we audited these maternal deaths, we found that these deaths could be avoidable. And we categorized them into three broad categories. That is patient-related, and sometimes patients don't present or to the healthcare facility on time. They don't attend antenatal clinic as frequently as they should, or they don't book early. Then there's also system-related failures, lack of ICU beds, referral problems. If we have a referral pathway system in South Africa, so low-risk women attend midwife obstetric units or district level hospitals, and once they develop risk factors in their pregnancy, they should be referred to regional or tertiary hospitals, and sometimes this doesn't take place. Also, recognizing and making a diagnosis and working aggressively, especially with these bleeding cases. And I see in Ghana, bleeding is also a problem, similar to South Africa. And sometimes the amount of bleeding is underestimated. Yeah. So what we've done to try and reduce the number of maternal deaths is to develop protocols for hypertension, hypertensive disorders. We've advocated for prevention, and one can prevent these hypertensive disorders by administering aspirin early in the pregnancy, but this should be done before 16 weeks. So we need to make contact with the pregnant woman before she's 16 weeks. And studies have shown if high-risk women get aspirin and calcium, we can reduce the incidence of hypertensive disorders by about 60 to 70%. So that is part of our protocol. We've also developed protocols for the management of hemorrhage disorders. We've observed a decrease in both of these conditions, but during the COVID pandemic over the 2 years, we had an increase in hemorrhage deaths, and this probably reflects some of the shortcomings in the healthcare system, because I think hemorrhage death reflects the strength of the healthcare system. And during the COVID pandemic, our healthcare system was under strain, and we saw a bit of an upsurge of our hemorrhage deaths again. So I think patient education and educating the public about conditions associated with pregnancy, strengthening the healthcare system, having motivated healthcare workers, ensuring that there are evidence-based protocols in place. We need to have the essential drugs available, and our infrastructure needs to be up to date. In our technology that we need to manage patients need to be up to date. And those are the important factors that we need to look at if we want to reduce our maternal death.
Thank you very much, Professor Pryor. Let me get to Dr. Chim once again, and then also tell us, what do we do with all these numbers, and how do we improve the situation in Sub-Saharan Africa? Just 2 minutes, and then we are done with you, so that we can regroup probably next week. We'll look for appropriate time, and then we can reconnect once again. Dr. Chim, if you can hear me, kindly help us. What do we do with all these figures that we are hearing?
I think I agree with what Prof has said. I think education within our African context is important. And also working together with policymakers for rural areas to have accessible antenatal care. Many of our women in Sub-Saharan Africa, in the rural areas, access to antenatal care is limited. And also the places where they go to give birth, some of them, they've got long distances to go. So I think it's not a single one-way solution, but it requires multidisciplinary solution. Government working with academic institution, working with non-governmental organization, charitable organization, even faith communities, and even other healthcare workers on the ground. That would help. If women don't access antenatal care, then they will present late, sometimes with very advanced severe preeclampsia or even eclamptic fits. And that's why hypertension probably is still one of the problems. But from policy making point of view, making drugs available, antihypertensive drugs during the antenatal period, and even drugs that simple as like magnesium sulfate that can prevent eclamptic fit or women having seizures during pregnancy because of high blood pressure, that would also be important. So it needs at all angles, government policies, healthcare workers, academic institutions, and also our audiences, our members, our women, our public, to be aware when to seek help early and not to ignore the signs at the community level.
And your last words, quickly? Our time is fast spent here. We're wrapping up with you.
Yeah, for my last words is to say, let's work together for a common goal. One death is too many. No woman should die from avoidable death.
Thank you very much, Dr. Chim. Now to the studio. Dr. Boafo is here from Ghana's perspective. As a consultant, you have opportunity of engaging the policymakers. What is the way out from your point?
Yes, the way out is we need to improve the quality of the care patients receive. When we talk of quality, the care must be very time-use. They need to receive timely services. For every maternal death, there's always a window of opportunity. A lot of the time, that window of opportunity is missed, either because the patient delays in coming, or the patient didn't take the decision to come to hospital early, or the patient did not receive the most appropriate care in a time-use manner. So quality care must be improved. It has to also be safe. When patients also know that it must be also respectful. When patients also know that, they are so much respected and all that, it also improves their coming to the institutions. So respectful maternity care is one of the ways to go. We need to improve our quality. And then, of course, we need to strengthen the health system. Strengthening the health system is a big thing, but one of the major pillars is governance and leadership, financing. The other things, the health workforce, of course, supplies of drugs, the delivery of the service itself. But one of the key things, financing of the health service.
Financing.
And leadership and governance. We need a lot of commitment on the part of leadership. Because maternal mortality is preventable. It is when we all put our hands together, and if the leadership is very, very committed to it, we can make we can go further. But if at leadership level, governance level, the commitment is small, we'll be talking and talking, we'll not make very much impact. So I think my big thing is we need governance, leadership, financing of the health system. And then, of course, we should motivate our health workforce.
To stay true and commit to.
People should accept posting to the various rural areas where a lot of deaths are occurring. If we do all this, because maternal mortality prevention is everybody's show.
It's everybody's business.
Everybody's business. It's not just one man. It's all of us.
Dr. Theodore,
we must all get involved.
Boafo.
Thank you very much.
Well, we'll find time and regroup, settle and talk more. But let me give a final bye to our professor who is reaching us from South Africa. Finally, Prof. Pryor, what is it that you can say the way forward in 30 seconds?
What I'd like to say is that if a mother dies, it does not only affect that mother, it affects the child,
Sure.
the family, and the entire village. So I think, like Dr. Chim said, it's important that we all work together to reduce our maternal mortality. And this is from the stakeholders to the public, to the doctors working in the healthcare system. Let us look at ways in which we can work together to prevent our mothers from dying. Thank you.
Thank you very much. So that was it. We just want to give a part one here. We'll regroup and expand it, because if you look at the time, we had a limited time to do this very important discussion. So we'll find time again, and I promise you and viewers to bring all these great men and women across the world who are doing well around the health sector to also continue the conversation. But many thanks to all of you. Earlier, you heard Dr. Chim, who is also in the UK. He is an obstetrician and a gynecologist practicing in the UK as well, and president of the Christian Healthcare Professional Network, subsidiary of the Church of Pentecost in the UK. Earlier, our Professor Prior Soma Apele, who is also head of department for the University of Pretoria, South Africa, and also a chair for the Stibiko Academic Hospital as well. Thank you so much. Then in the studio, my great doc, Dr. Theodore Boafo, who is also a senior lecturer at the Ghana Medical School and also a consultant obstetrician and gynecologist. My name is Joseph Beldankwa. We'll see you some other time, very, very soon. We'll bring all these people together again and continue the conversation. But wherever you find yourself, let's do our best. Education is key. But if you have a pregnant wife, a woman, a friend around, please always lead him to the nearest clinic. You can help by saving life. Direct them as well. Ensure their safety. And then to our health professionals, please, let's stay and do our best, okay, to make the health sector also good for everybody, so that health delivery and healthcare services will be proper for all of us to stay in. In Sub-Saharan Africa, we need to work more. And leadership, for that matter, governance level, I think we must have to up our games. And then finances must be committed into the various health sectors, so that the various infrastructures and then the needed medicines will be released on time to save the situation, because the matter is not exciting at all. We'll see you, God willing, on Monday. Enjoy your weekend. Bye-bye.